Chapter 10, Antiviral Agents. When we talk about these, we think of medication viruses that respond to antiviral therapy. Some viruses don't respond to antiviral therapy. Viruses that do respond to antiviral therapy include influenza A, some respiratory viruses such as RSV, herpes virus, cytomegalovirus, HIV and AIDS, hepatitis B and C, and viruses that cause warts and certain eye infections. Characteristics of common viruses: it cannot replicate on its own, so it must attach and enter a host cell. It then uses the host cell energy to synthesize protein and make its DNA and RNA. Viruses are very difficult to kill because they live inside our healthy cells. Any drug that kills the virus must also kill our cells, and you'll see on the next slide the stages of virus replication. When we think about drugs across the therapy, children are sensitive to the effects of antiviral drugs, so you may see more severe reactions when used. Also, with adults, we need to ask questions about the viral infection. And remember, if it's a viral infection, we do not want to prescribe an antibiotic because it can lead to superinfections or resistant strains. Patients with HIV infection who are taking antiviral medications need to be educated that these don't cure, and we want to, with pregnant ladies, outweigh the risk and benefits. And also with our elderly, patients are more susceptible to adverse effects, so we want to monitor our elderly closely. We also want to assess for hepatic and functions if their liver isn't working properly. Common respiratory viruses include influenza A, influenza B, and our pediatric population gets the respiratory syncytial virus, which is also known as RSV. They're known to attack the respiratory tract, and for these viruses, vaccines have been developed to prevent the viral infection. The most common vaccine, we don't talk about vaccines in this chapter, we'll talk about it later in this semester, but the common treatment for this, for influenza A and influenza B, we're going to have our provider prescribe Tamiflu. And when our patient complains of these respiratory viruses symptoms, it's the virus enters the body and the patient experiences cough, fever, chills, inflammation of the nasal and mucosal respiratory tract. Right now we're going to talk about agents for influenza A. This splitting of the viral protein coat, that's just to help you. When I think of one of these that we give a lot is Ritonavir. We give that a lot to treat pediatric patients with RSV. Another one you might see is Oseltamivir, also known as Tamiflu. You have to start the Tamiflu somebody who's symptomatic within the last 48 hours, and it's twice a day for 5 days. You can also give Tamiflu preventatively, so if your family member's sick and they get started on Tamiflu, you can also be prescribed Tamiflu, and you'll just take that once a day. When we think of these agents, we want to realize that they can cause dizziness and insomnia, so it's affecting the central nervous system. It can have effects on the dopamine level, it can drop it. They're also at risk for orthostatic hypotension. And drugs that can interact with your agents for influenza A and respiratory viruses are anticholinergics, so they may experience dry mouth, blurred vision, and urinary hesitancy, which could lead to urinary retention. When we think of our patients with respiratory antiviral therapy, we don't know if they have any allergies or history. We always want to assess our liver and renal dysfunction because it can play a part of how it's excreted. If they're pregnancy or breastfeeding, we want to understand that we need to outweigh the risk and benefits. We also want to assess their vital signs because they're at risk for orthostatic hypotension. And we always want to educate our patients to get vaccines at the beginning of the season to prevent influenza and respiratory viruses if prescribed. Ranitidine is just prophylactic treatment of illness caused by influenza A in adults, and it can be used in children also diagnosed with influenza A virus. And just remember they're at risk for orthostatic hypotension and depression. The answer to this is true. A virus must enter a human cell to survive, making it difficult to treat without serious toxic effects for the host. Now we're going to discuss agents for herpes and cytomegalovirus. And when we think of the herpes virus, it's painful vesicles that occur in clusters on skin, cornea, and mucous membranes. I also think of this as the cold sores. You can also have shingles, which is also known as herpes zoster, or a genital infection. Usually this primary disease lasts for 2 weeks, and the duration of recurrence varies from patient to patient. They can also I don't know what I was going to say, so keep going. Signs and symptoms of the cytomegalovirus, or also known as CMV, affects the respiratory, the eyes, and liver, and reacts to many of the same drugs as herpes viruses do. So patients may be asymptomatic. They may also experience fatigue, nausea, and jaundice. Typically, this is contracted during pregnancy and can result in stillbirth, brain damage, or birth defects. When thinking of herpes virus medications and CMV antivirals, we need to think of, on page 148, there's a whole box, but I picked out the 3 most common that I think you'll see. So the first one you're going to see is Acyclovir, and this is used most often for patients with herpes virus infections, and you also see it a lot with herpes zoster, also known as shingles. The next one you'll see is Valacyclovir, and you'll see that one a lot, most likely with recurrent genitalia herpes. And another one you may see, because we're talking about AIDS patients, antivirals for AIDS patients next in this chapter, you'll see the Zidovudine or Visitide, and it's treatment of the CMV, retinitis, and AIDS patients. When we're talking about herpes and CMV antivirals, we need to realize they're going to inhibit the DNA replication. This is highly contraindicated in patients who have renal disease, also highly toxic for patients who are pregnant and lactating. Patients may experience nausea, vomiting, headaches, rash, possible hair loss, paresthesia, neuropathy, and renal dysfunction when giving these medications. We want to use precautions when we think of our drug-to-drug interactions. This is just for your knowledge. It won't be tested on. Is that it's going to interfere with nephrotoxic drugs. That's why we don't want to use it on our renal impaired patients. Zidovudine and aminoglycosides. And think back to when we talked about, in the last chapter, aminoglycosides. That would include your gentamicin. We also want to use the Zidovudine, which is for the retinitis, CMV, cautiously in children with AIDS because it can have carcinogenic effects and has effect on fertility. When we're thinking of nursing considerations for those herpes virus and cytomegalovirus, we want to get a good patient history, and we want to get a baseline for their CNS effects because patients taking these medications can and may develop hallucinations. So we want a good CNS effect baseline. We need to know their orientation. We want to know their skin, color, temperature, and if there's any lesions, because that's what we're treating, make sure it's getting better and not worse. And we also, because it's hard on the kidneys, we want a renal function test. And this one here is just talking about Abacavir, and you can read through that. Next, we're going to talk about agents for HIV and AIDS. And when we think about HIV and AIDS pathophysiology, we need to remember that it attacks the helper T cells in the immune system. The cells lose its ability to perform normal immune functions and continue to invade. Patients begin to experience fever, rash, and myalgia, which is tiredness. They can have asymptomatic infection for a long period of time following acute infection, and the duration varies. Patients may experience persistent generalized lymphadenopathy. Patients may voice symptoms as fever lasting more than a month, involuntary weight loss, and chronic fatigue. And over the course of the patient's life with HIV and AIDS, they can develop the neurological disease of dementia. When we think of also other signs and symptoms of HIV and AIDS, they can develop secondary infections such as pneumonia, disseminated herpes simplex. Treatment is awful difficult because the virus can lay dormant for months to years, and adverse effects of AIDS treatment medications may lead to decreased immune systems. Drugs used to treat HIV include reverse transcriptase inhibitors, protease inhibitors, nucleosides, fusion inhibitors, integrase inhibitors, and CCR5 core receptor antagonists. And I'm going to give an example at each of these before I talk about them, one or two examples, so you don't have to memorize the whole chart unless you plan on working at an HIV or AIDS clinic. It would be beneficial. When using these drugs, you need to use at least 3 of these medications to achieve maximum effectiveness. They all attack the virus at various stages of the virus's various stage of life. Non-nucleoside and nucleoside reverse transcriptase inhibitors work together. They indicate that they bind directly to HIV, reverse transcriptase, blocking both RNA and DNA. When we think of these were the first class of drugs that were identified for HIV and AIDS patients. You don't want to take the non-nucleosides with calcium channel blockers. And these are contraindicated for pregnant and lactating women, except the Zidovudine, which is a non-nucleoside. And our patients may experience nausea, vomiting, diarrhea, along with dry mouth, headache, rash, chills. They may complain of flu-like symptoms. The Zidovudine can cause bone marrow suppression. That's just extra knowledge. Don't focus on that. You also want to, with the nucleoside reverse transcriptase inhibitors, you want to watch for hepatomegalia and hypersensitivity, such as fevers, chills, and rash. So, and also on the exam, don't focus on memorizing all of the box of names shown on page 151 and 152. I will give you the drug classification, if it's a non-nucleoside reverse transcriptase inhibitor or a nucleoside reverse transcriptase inhibitor. So just be aware of that. Inhibitors block the protease activity within the HIV virus. And protease is essential for the maturation of the infection virus. And its medications are typically absorbed through the GI tract. And we want to use contraindications with our pregnancy and lactation, and patients with mild to moderate hepatic dysfunction, which affects the liver. We want to also, at this time, it's very important to educate our patients with HIV and AIDS not to breastfeed because the virus could be passed on through the breast milk. Adverse reactions, they can have GI effects, nausea, vomiting, diarrhea. They could have change in their liver function. They can have elevated cholesterol and triglyceride levels can occur. And also, they can have Stevens-Johnson syndrome. They're at risk for it. So this one, if you have an AIDS patient, you could put risk for Stevens-Johnson syndrome. You want to educate your patient to avoid antihistamines, sedatives, and antiarrhythmic medications, such as like your cortisone. Fusion inhibitors are a newer class of drug. This agent acts at a different sites than do other HIV antivirals. They prevent the fusion of the virus with the human cell membrane. Enfuratide, or Fusion, is used in combination with other antiretroviral agents for adults and children over the age of 6 who have evidence of HIV-1 replication. It's given subcutaneous, and it peaks in about 4 to 8 hours. That's just extra knowledge, so don't memorize the times. We're going to use this cautiously with patients with lung disease and also our pregnant women. Patients may experience insomnia, depression, neuropathy, pneumonia, and injection site reactions. There's no drug-to-drug interactions reported, but you do want to use this cautiously. The next one we're going to talk about is a CCR5 core receptor antagonist. The drug in this class is relatively new, and it was called Maravicor. It blocks the receptor site on the cell membrane to which the HIV virus needs to interact to enter the cell wall. You want to use, patients are at risk for hypersensitivity to this. This drug has a black box warning for severe hepatotoxicity, so you want to be checking those liver functions routinely. Patients may also experience dizziness and changes in level of consciousness. They're also at risk for infections, but I would say that with all HIV and AIDS patients. Drug-to-drug interactions, you do not want your patient using St. John's wort. It can also have increased serum levels and toxicity when combined with other inhibitors and other HIV/AIDS medications, so you just want to check with that. Also, don't forget, you're not going to use one of these drugs as a standalone drug. They're going to be on at least 3, if not 5 to 6 of these medications, each drug class. They're going to combine each drug class. They'll be on one from each drug class, and they're all working together to prevent the HIV replication. The next thing we're going to talk about is integrase inhibitors. And these inhibit the activity of the virus-specific enzyme integrase. And this enzyme is needed for viral replication. Patients can have severe allergic reaction to this medication as well. And common adverse effects include headache, dizziness, they can also be at risk for an increased development of rhabdomyolysis. You should also avoid using St. John's wort as well. When we're taking care of our HIV and AIDS patients and they're on these antiviral therapies, there's lots of nursing considerations. First off, sometimes HIV is hard to diagnose because the symptoms also mimic flu-like symptoms with the fever, chills, just general body aches. But once they're diagnosed, they're going to complete this course and they're going to follow a combination of medications. 3 of the 6 are typically prescribed. If they've been on this regimen for a while, we need to assess their allergy history because they may already be allergic to some antivirals. We also want to assess their renal and hepatic function because sometimes they have a great impact on interfere with metabolism and excretion of the drug. We also want to know if they're pregnant or lactating, so we're giving the safe, right dose of medication, and it won't have any adverse effects to the fetus. We want to do our physical assessment to establish a baseline, and we want to evaluate for any central nervous system effects of the drug. We want to assess the skin, make sure there's no any lesions or open lesions. And we want to monitor their temperature on a routine basis because they're at risk. HIV and AIDS patients already have an immunocompromised body system, so they're at risk for medications. Also, I just want to mention this, that patients who take antiretroviral agents are at risk for diarrhea, and there's an antiretroviral drug for diarrhea. So it's called clofazimir, and it works on the GI tract to stimulate chloride ion channels and calcium channel, which blocks chloride secretion. It is only approved for symptomatic diarrhea patients on You are caring for a patient that has been diagnosed with herpes simplex and are given a prescription. Well, this should have been earlier. What should you teach the patient about taking their medication? It's A, you want them to start taking the medication as soon as possible to improve effectiveness of the antiviral activity. You are caring for a patient with HIV. A nursing diagnosis for this patient is acute pain related to site reaction of the drugs. What type of drug is this patient taking? The answer is B. A. No, it's actually B. And because acute, I said it's given sub-Q and they're going to have pain at the injection site. That's just for your knowledge. It's not, you may see it on boards, but highly doubtful. Hepatitis B is a fatal viral infection of the liver. It can be spread through blood, sex, or contamination through a blood transfusion. When we give anti-hepatitis B agents, it causes DNA termination. Examples of these meds include Atazanavir and Zidovudine, which treats chronic hepatitis in adults. And the second one does children less than 16 years of age as well. We want to make sure patients taking this are not pregnant or lactating. And we also just be aware and cautious of patients with known renal and liver disease because they're not going to excrete it and metabolize the drug like a healthy adult would. Adverse effects include headache, dizziness, nausea, diarrhea, and we'll see elevated liver enzymes. Probably before administration, but if they also increase when the patient starts the medication, we want to use risk. We want to use extreme caution when giving these with nephrotoxic drugs because they have an increased risk for renal toxicity. We also want to use extreme caution when patients are taking this. We don't want to stop the med on their own independently because it could cause Hep B exacerbation and they'll have more symptoms than they would with the medication. As the nurse caring for this patient, we want to assess their allergy history as always. We want to get a baseline liver and renal function test. A complete metabolic panel would help with this diagnosis. We want to get a good physical assessment. And we also want to get establish their central nervous system to make sure they understand what's going on. We want to get a good temperature to monitor for any underlying diseases. And back to the neuro system, if they're not orientated, they may have high ammonia levels, which means their liver's not working properly. When you think of this Atazanavir, it's treatment of chronic hepatitis B, and they can have headache, nausea, severe hepatomegaly with steatosis is just the fatty part of the liver. And if they stop it abruptly, they'll have exacerbation of hepatitis when it's discontinued. So continue to take it. Educate, educate, educate. Take their meds. When our patient's been diagnosed with hepatitis C, they've had blood exposure. They could have been born with hepatitis C from their mom. They could have got it with having intimate sex with a partner that's been infected, or they could have got it sharing a razor or toothbrush. Patients with hepatitis C, they could be a candidate for a liver transplant. And when we talk about anti-hepatitis C agents or medications, these are relatively new, and they are protease inhibitors specific to the hepatitis C virus. They must be combined with a protease inhibitor, such as ribavirin. And we want to monitor the liver function with these medications. So just be aware of that. Last but not least in this chapter are our locally active antiviral agents. Some of these that I think of that are important are your Abreva that you use. Those are used to treat local cold sores and facial herpes. And then another one is imiprimide or Aldera. It's local treatment of warts and genital and perianal warts. There's also ophthalmic ointment to treat herpes simplex infection in the eye. So just be aware that these are out there. They act on the virus by interfering with normal viral replication. The side effects of these medications is there's no systemic effect, but they can cause local burning, stinging, and discomfort. And when I said Abreva earlier, the actual generic name is docosanol. So just be aware of those for your life practice. If we want to assess the patients, I'll go over that on the next slide. When we're taking our patients that are having these local active antiviral agents, such as docosanol, which is Abreva, we want to make sure we're assessing the lesions they have that are infected, including the location, size, and characteristics. We want to assess signs of inflammation at the site of infection. And we want to make sure it's working. We want to make sure the patient's using the proper administration technique. And we want to watch for the response. And the patients may have adverse effects of more increased local irritation and discomfort at the site. So that medication may or may not be working for their local, like if they have a cold sore. Okay, last question of the day. Which antiviral drugs are not absorbed systemically? And the answer is locally active antiviral agents. But we want to use them cautiously in patients who have known allergic reactions to any topical medications. So just be aware of that when we practice with these. When treating patients with agents for influenza A and respiratory virus, ideally we want them to prevent the viral infection, but if unable to do so, drug therapies are available. We want to make sure patients with AIDS, there's 6 classes, so I'm probably going to give you the classification, and you'll have to make sure you understand that. And make sure you understand that with HIV and AIDS, we're not going for a cure, we're just going to slow the disease process. We also want to know with patients who have herpes and cytomegalovirus, what agents work for that. And when we give Aciclovir, what's it helping? It's helping the herpes simplex, the herpes virus infection. And that includes herpes on the mouth. It can include herpes zosters. It can include genital herpes or cold sores. And patients who are being treated with Aciclovir and they have possibly the CMV, we need a good neurological assessment because they're at risk for hallucinations. When we're taking care of these patients with all these antivirals, especially the HIV and hepatitis B and hepatitis C, we need to know their liver function tests and their renal function tests. So just remember those as you continue to practice. And then local ones, local active antiviral agents, they're only local and not systemic. And just remember patients, with all of these, they have immunocompromised systems. So they're at risk for developing other infections as well.